Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. Here this morning with Dr. Caitlin McCulley. We've actually been having a great conversation this morning already about Alani and lemon lime flavors. And
yeah, this is my first time trying the lime one, and it's interesting, but it's good. I don't hate on it.
You know?
Yeah.
I didn't even know what an Alani was till
I'll teach you something
about 10 minutes ago. I'm learning about some whole new caffeine delivery systems that didn't know even existed.
Yep.
Like I'm over here thinking I got coffee and Diet Coke.
I feel like you would like the cherry bomb one. It kind of tastes like Dr. Pepper.
I'm going to have to do this. I'm going to try these.
I'll bring you one sometime maybe. They have little baby ones.
I mean,
it's like half this size.
I'm a vet. I need all the caffeine.
I'm just saying.
Like we run on like caffeine.
If you want to just dip your toe in the water and not go with the tall boy, I'll get you a little baby can.
I'm gonna go big.
Okay.
I mean, been thinking about changing and getting a T-shirt that says we run on caffeine and Banamine.
That's true.
So
yeah.
So speaking of caffeine, this segue actually has nothing to do with our topic today. But you know what?
I was like, where are you going with that?
Yeah, it just sounds like, I feel like if you say those words, right, if you're like speaking of, and then you jump to the next topic, everyone just goes with you. So that's what we're going to do. Speaking of caffeine, let's talk about blood work.
Because I drank a lot of caffeine when I was learning about interpreting blood work.
We can go with that.
There you go.
Yeah.
I drink a lot of caffeine all the time, but that's fine.
Yeah. Today we're going to talk a little bit about blood work in horses because, I feel like this is something happens at a lot of appointments. A lot of times when we see the horse, we're like, let's run some blood work. Mm-hmm. And we're always doing that. And people are like, okay. Or people call us like, hey, can you run some blood work? And I'm like, sure. Which one?
Yeah. There's a lot of options.
Blood work. I'm like, okay. Well,
which one?
Which one? Like, all right, let's examine. And that's where we're going to end up eventually. Is like blood work, got to have a clinical exam, figure out what blood work we need, and go from there.
You have to treat the horse, not the numbers. The numbers help, but treat the horse, not the numbers.
So let's start with, if I had to say this, I feel like the foundation of everything. I feel like if you're running any kind of a diagnostic test, if you're running any kind of blood work, if it's a Cushing's test, insulin test, Lyme assay, if you feel the need to test something with blood, I feel like it needs to be paired with this test, and that is the good CBC chem.
Oh yeah,
just plain simple. I feel like it gets forgotten a lot, but to me, if you're going to run any other test involving hematology, you need to couple it with this one because obviously something's going on that says your patient's sick.
Yeah.
So we need to include this.
Yeah.
So
CBC Chem is kind of what we call our basic blood work. It's a basic panel. And so your CBC is a complete blood count that tells you red blood cells, which are your oxygen carriers, white blood cells, which are your immune cells, your defense system cells, your antibody cells, all of those, and then platelets. In horses, the platelets are not super helpful.
So let's just get these two things out of the way right now. If you get blood work back and you see that thing that says RBCs or HCT on it, you want to grab. I always like to say we need to highlight this with a Sharpie. Mm-hmm. Just color that in.
Yeah.
The only way to accurately measure red cells in a horse is you have to do a manual hematocrit.
Yes.
Or we call it packed cell volume. We spin it down. Because the problem is the red blood cells in the horse, they're so variable in sizes. And basically this machine, it's kind of cool the way it works, right? And I'm probably the only nerd that knows this, but it passes everything through a tiny little aperture. Mm-hmm. And it literally counts one cell at a time.
Yes.
And then based on size, it knows what kind of cell it's looking at.
Mm-hmm.
I mean, there's some other factors, but size is one of them.
Yeah.
So in horse red blood cells, they're so variable in size, cannot accurately count.
Yeah.
So if you're looking at your horse's blood work and you're like, oh no, he's anemic, he's got no RBCs.
Hold on.
Hold on. Highlight that with a Sharpie, reread.
Yes. Yeah.
Because you've got to have an actual pack. It's like when we bring in-house blood work here, we always say, hey, get a CBC Chem, PCV total solids.
Correct. Yeah. There's another
every time.
Little friend that goes along with it. And then same with the platelets. The platelets always read low on our machine because they clump and you can make a blood smear and you're like, oh, they've got platelets everywhere, but the machine can't read them appropriately. So those are two that we have to kind of put an asterisk on and say, hey, we got to do some more digging to see if this is real or not.
Yeah. Highlight with a Sharpie, throw the number out.
Yeah.
Move on to a different test to figure that out.
Yeah.
So I just wanted to get that out of the way.
Yes.
Because you know I was going to go there. Nothing drives me more nuts. Oh, he's anemic. Like, did you do a pack cell bite? No. Then you don't know.
Yeah. You don't know for sure.
Yeah.
But CBC is helpful to tell us about signs of infection, inflammation, but also, like things like lymphoma, overwhelming infection where they've lost all of their white cells.
Mm-hmm.
You can have, bone marrow disorders where they're completely not making the cells. So it can cue us into a lot of different things, but mainly we're reaching for that for infection and inflammation.
I always think about when you look at them, and these are guidelines, right? None of these are rules, but I call them guidelines. Each cell kind of has its own little job.
Oh, yeah.
So it kind of helps steer us to what may be going on.
Mm-hmm.
So when we look at a white blood cell, it's broken down into a lot of different, like when you see WBC on there, a white blood cell, it's got a bunch of little friends.
Under it, yes.
And depending on which one of those friends is high, maybe telling us what's going on. Or low.
Yeah.
I feel like we're about to roll into a whole podcast on CBC if we keep going, or do we? It's
so cool.
Let's talk a little bit about CBC.
Yeah.
And you know what? If we happen to take up the whole time, then
we're looking at patterns. So we're looking at patterns in the changes of those white cells, because very rarely do just one of those types of white cells change on their own.
Right.
Oftentimes you're looking at a pattern, like your monocytes will be high, your lymphocytes will be high, your neutrophils will be low, or vice versa. Like they will shift in a pattern, and we can recognize those patterns and pair those up with what's going on or common disease processes in the horse.
I always like to say I like to look at that white cell, and if I see that up, I got to go see why it's up.
Mm-hmm.
And then that's going to tell me where I need to go. And
yeah.
Because all of a sudden, if you're like, oh, white cells are high, and you look down and neutrophils are really high, you're like, oh, there's some badness. I got a bacteria hiding somewhere.
Yeah.
Like we're building an abscess.
Right. Or if your white cells are really low, I'm like, well, where are they going?
Yeah, exactly. They have left the building.
They're going somewhere.
Because it's called margination. It's called marginating.
Mm-hmm.
White blood cells are supposed to be toxin.
Yeah.
It's really cool. They're like floating around in blood vessels, and then they actually start rolling.
They're
like
stuck,
tumbling along the edge.
Yes.
And if there's a problem and the signal goes out from where that problem is, they'll actually marginate through the blood vessel and start crawling its way to where the problem is. It's so freaking cool.
So they're literally going somewhere.
They're going somewhere.
Mm-hmm.
They're literally on a road trip. They're like tumbling down the interstate. They get off at an off ramp and navigate their way over to where this problem is. And they ain't got no legs.
Mm-mm.
Lieutenant Dan, no legs.
No legs.
And they get there.
Yeah.
And I've seen the video. Did you all get to see the videos?
Mm-hmm.
Oh, it's so cool.
Where they roll along the thing.
Yes, you can actually. It's probably on YouTube if you look at like white cell margination. And if you're a nerd, you need to go do that. Like right now, we'll wait for you to come back to the podcast. Go look it up right now. If you're driving, pull over and do this because it's really, really cool. So yeah, neutrophils. I'm often thinking bacterial infection, and we got to go find that. Where do they go? So they can be low, and it's a problem, or you've got like 20,000 of them.
And you're like, And
you're like, are we at the beginning of this infection, or have we been cooking for a while?
Right. Yeah.
So, and then it's like off on the hunt, right? We got to go find the white cells.
Yeah. And you can, like, and this is where we have to go down a path of like, you rule out your common things, like your common locations. And then you're like, well, where else is it biting? Is there a wound? Is there an abscess? Is there something in the guttural pouches? Is there something in a uterus? Is there something in a bladder? Is there something, there's lots of places where they can hide. That's not like our first line of defense, essentially.
Got to go looking.
Mm-hmm.
And the crazy part, too, is if this goes on long enough, if you've had, let's say in the case of like a slow peritonitis. Mm-hmm. In fact, we just had this the other day.
Yep.
We were actually returning back to normal on the blood work. But yet we had like 40,000 neutrophils sitting in the abdomen.
Yeah.
But basically, it becomes status quo.
Right.
That we're pumping out neutrophils to go to the abdomen. It becomes status quo. It was a long-standing issue. Mm-hmm. And so our blood work had actually returned to normal. But we had this one brief blip where it went up.
Yeah.
And we caught it at the right time. Uh-huh. And then while we're here, like, it actually returned to normal, but that was... And it had been normal, I think, the week before that.
Mm-hmm. And this is an important point to bring up because blood work is a snapshot in time.
Yes.
It's only that specific time, that specific day. Like, it does not, just because you ran blood work 2 days ago does not mean that it's going to be the same today, which is why, like, people, they'll talk about getting baseline blood work done, which is great. I love to have a baseline. Mm-hmm. But if we don't have serial baselines on that horse, like every 6 months to every year, I don't know if that's truly baseline or is that something's going on. But
I've got a horse that runs a low neutrophil count down around 4,000.
Yeah.
And I can go back and I've got 10 years worth of data on this horse. He lives at 4,000.
Yeah.
And actually he got sick one time and another vet actually saw him. He was out of town. And like his neutrophils are 4,000. I was like, and that's okay.
Yeah.
That's where he lives.
Yeah.
For at least the last 10 years.
Yeah.
That's where he lives.
And in that aspect, it's great to have a baseline. Mm-hmm. But if we pull blood work one day, that's just a snapshot in time.
That's that day.
Just that day.
And there's times where we've had several of these where it took multiple checks. Like we know there's something going on. We can't put our finger on it. Mm-hmm. And it took 2 or 3 times, sometimes a week. I think the one we found back in January, the lymphoma. It was like 3 weeks in a row of having these cock-like symptoms. Knowing by the time we got there, we kept rechecking blood work.
Yeah.
And everybody's like, well, why do you keep doing that? I was like, there's something here. We have to catch it at the right time.
Yes.
And boom, we did.
Yeah.
And then we knew what to go do next.
Yeah. And people will get frustrated because they're like, well, you just did this last week. I'm like, I know.
I get it. We have a problem and we don't know where to go look.
Correct.
We've got to figure out where to go look next.
Yeah.
It's kind of the nerve block of internal med when you kind of think about it.
Okay.
I mean, if you really think about it, it is.
I'm just out here blocking horses all the time, Dan.
You just out there blocking horses. Welcome to Sports Medicine.
Okay.
Yes, the nerve block. You're just trying to localize where to go look, right?
That's true.
In fact, I actually argue that, I always say I'm a C+ student here. I got to keep things real simple. Like that's my whole key to life. I got to keep things simple. My brain to keep up. And so I always say like medicine to me is like a lameness exam. Lameness exam is they lame, not lame.
Yeah.
Wet leg.
Yeah.
Localize it with a block. Once you get it localized, you image it. And that's all I do all day. Mm-hmm. And I took the same thought, like I don't care what kind of case walks through the door. Is it sick, not sick? Body system affected.
Yeah.
Image it.
Yeah.
But I consider blood work imaging.
Yes. Yeah.
Blood work is imaging.
Yeah.
Like if you had a respiratory infection, you would ultrasound it. That's imaging. But that blood work's also imaging. Mm-hmm. Because it's going to tell you what cells are there. Mm-hmm.
Yeah.
So I argue and that's how I work up. Every once in a while, y'all let me do an internal med case, and I'm like, all right, let's go. We got to go image this thing. What do we do?
What, get our imaging.
Yeah. And so I consider blood work imaging, and now I'm gonna call it the nerve block.
It's a nerve block. That's crazy.
Localizing.
That is it's a good way to put it, though.
Yeah. So we're diving in, and we got to go figure out where these things are going.
Yeah.
And so I think that's that's kind of our little hunt, right? Mm-hmm. And there's easy because you can look on the skin and be like, do you got any wounds anywhere? Nope.
Cross that off the list.
Now we got to go look internally. And that's where we start looking at thorax. And that's kind of cool because there's only so many places they can hide.
Right.
But it's like a little mystery game.
It is.
Where the neutrophils go.
But it works so closely with your physical exam because the physical exam is going to cue you in first off. And then it's going to help you. They all just intermingle and work together. And
yeah, because if your lungs sound like crap and your neutrophils have disappeared,
yeah, you know where they're going.
Let's go look there.
Yeah. But yeah, I usually recheck. If I have a sick case in the hospital, I usually will recheck blood work like every 48 to 72 hours is kind of my recheck. But it is a snapshot in time. If we ask to repeat blood work, there's a reason.
Yeah, and that's important too, like doing these rechecks, especially on the CBC land, because if you got that elevated white count, let's say you started on antibiotics, a lot of times, let's say if we got an infection, we're waiting on a culture, we can be 3 to 5 days getting a culture back. We start on antibiotics, we recheck that in 48 hours. We get a really good idea. Did we guess right? Yeah,
did we choose right? But I will say, lab work without a physical exam means nothing.
It's kind of like x-rays without an exam. Correct. They're just pretty pictures.
Yes, pretty pictures.
Gotta have that clinical exam.
Correct.
Gotta have it.
But then going hand in hand with our CBC, we're looking at these white cells. We're looking at, potentially where they're going. The other thing that can cue us into where they might be going is your chemistry.
Yeah.
And so your chemistry it's a serum chemistry analysis. It tells you basically, it's going to look at liver values. It's going to look at kidney values, muscle enzymes, some electrolytes, proteins, and then glucose. I'm trying to look at my little chemistry strip in my head.
You kind of hit it.
I think that's everything.
And I think this is important too. When we say we're running a chemistry, if I go grab the IDEX book, there's a whole section on different chemistry profiles.
Oh yeah.
And so there's the one that we use in-house, and we said, this is important. We need these things. And we'll sometimes add an electrolyte panel. I've forgotten where I'm going to add the electrolyte panel almost every time.
I do like the lights panel. Yeah, it's nice.
But yet we can send it off, and these labs can run they can start adding different tests.
Oh, yeah. You can run 8 million things on your chemistry.
Yes.
Yeah.
It's pretty incredible.
Yeah, it's insane.
But if you hit the basics, I always look through and
I forgot Billy Rubin.
Oh, Billy Rubin.
Yeah.
Yeah. Basically, you're saying, like, what are my internal, what, how's everybody doing inside?
Yeah. It gives you kind of
Major
a holistic
organs.
Overview of your major organ systems and saying, like, okay, are we hanging in there? Is there anything that's given us a little bit of a tift in there?
When I think this is when I always say that where your exam is really important. You see elevated liver values. Those are up.
Yeah.
But you're also running a fever. You're also having elevated CBC.
Yeah.
The liver, oftentimes, it's not prone to get sick. But we also know it produces these things called acute phase proteins.
Oh.
We're going to talk about those later.
Yay.
And so a byproduct of being sick and producing those acute phase proteins is our liver values go up.
Yeah, because your liver's working harder. It's pumping out all these things, and those liver enzymes can go up. Yeah.
So we're not in there looking for cholecystitis. We're not looking for anything wrong with the liver.
Yeah.
I don't know why I can't say that word today.
Cholangiohepatitis?
Yes.
Cholestasis?
Cholestasis.
Cholangiohepatitis.
The George is killing me.
See, I'm normally the one that fumbles on those big words, and you can get them, but today we flip-flopped.
I know, but that one I always struggle with.
I've had a couple really good liver cases lately.
You have, though, so I guess I'm messing that up, because normally it's never the liver.
Normally it's not, no. But when it is.
Caitlin's like, Sarah, let me show you this.
Give me that thing. I can fix it, or I'll try really hard.
Yeah, that's where you got to look at. You got to look at the whole case, because again, you see that, and
does it make sense?
It doesn't. That's not the problem.
Yeah,
and you have to be able to look at the physical exam, look at all the blood work, and go, okay, yeah, my GGT's up. I'm sure it is. He's got 104-degree fever.
Yeah.
And I've got 3 neutrophils left.
However, if you bring me a horse that's yellow, and his GGT is sky high, then I'm going to be like, ooh,
we have a problem.
We have a problem. Yes.
Oh, look, his T-Billy is up.
Yes.
And he's yellow.
Yes.
Got an issue.
Yeah. But it's, again, clinical exam is your number one, and then the blood work is your nerve block and your imaging all kind of wrapped into one. So.
Yeah, and the other big organ we look at on that chemistry is, it's truly one of those unsung heroes of the body is the lowly kidney. Like we have talked about, we did a whole podcast on the kidney. We talked
extensively about the kidney.
I love the kidney.
Yeah.
And everybody forgets about the kidney until the kidney finally gives up.
Yeah.
And when the kidney does give up, we see it on blood work.
Yeah.
And I think that's the scariest thing we talked about in the podcast on the kidney. Like if you should go back and listen to that if you haven't, but you got to lose 75% of your kidney before we're going to see that on blood work.
Yeah.
So again, if we're suspect of clinical signs looking like kidney failure, even though we're treating, you may see us running chronic or running serial chemistries. It's because we have concerns about the kidney, and we don't need this showing up on us,
right?
And not seeing it,
not catching it in time,
right?
But yeah, the chemistries they're very helpful. You can tailor them to include
whatever you
want, really.
My big thing's muscle enzymes. Being a performance guy, I'm always looking at muscle enzymes.
Yeah.
And these are leakage enzymes, AST and CK. That's my jam right there.
Yeah.
I'm always looking at these guys.
Yeah.
Because there's certain neuromuscular conditions that can show up, and we see increases in those ASTs and CKs.
Yeah.
And also just having a heavily athletic horse, you can get increase in AST and CKs. That points us to what we call, most people have heard of as tying up, but it's exertional rapid hemolysis. But yes, I'm looking at muscle enzymes. I'm looking at electrolytes.
Yeah.
That's my.
Yeah.
And I will tell you this is one thing I did learn looking at a lot of blood work. Your horse has got to be really sick, and you have got to really screw some stuff up before you see electrolyte imbalances.
Oh, because of the kidneys.
There's the kidneys.
The kidneys they will try.
There's my plug for the kidneys. Again. Because we talked about the kidney.
Yes.
That was probably one of my favorites.
Yes.
We've ever done.
But yeah, so that's kind of your chemistry. But we can tailor it. Different clinics will choose different chemistry offerings.
Right.
Different universities will offer different things in their like chemistry package. And so, there's a whole lot of information we can get from those. And if we need something that's not on our basic chemistry panel, we'll send it out and say, hey, we need this, this, and this.
Again, if we do a physical exam,
we can.
And look at our clinical and go,
yeah.
I'm suspect of this. We may be like, okay, we're going to send this out because we want to change this panel a little bit.
Yeah.
So again, like if y'all learn nothing else from the Equine Vet Connect podcast, nothing else, it is the power of the physical exam. And to me, this is where there's this push for telehealth. You know what telehealth doesn't have?
A physical exam.
You looked at them, but that's using one sense.
Right.
There's the look, there's a smell.
There's touch. Oh, your hands or
your ears.
Yeah.
Like there's so much that goes into a physical exam that people. I was telling a lady one time. She's like, "We just stand there listening to it." I was like, "Ma'am, I'm listening to your horse's heart." But you realize I've looked up. I've seen that scar in his left cornea. I've seen the cut that's back here on this pastern. I've seen this. And I started listing all the things off that I was looking at while I was listening to her.
Yeah.
And she's never said another word. Like, I'm not just listening.
I'm looking. I've always got my hands on a horse while I'm listening. Like you get a lot of information very quickly.
So yeah, don't mean to diverge there, but again,
it's true.
It starts with that physical exam, and then that's going to determine what blood work.
Well, and that's what I try to teach every student that comes through here, and they teach you this in school too. But we hammer it home. It's like when you get to a case and you don't know what to do, you start with a physical exam.
Yes.
Every single time.
Yeah.
Takes you back to base.
Always do it.
Yeah.
I can't tell you how many have come in that we've solved on the physical exam. And all it does is tell us what step to take next.
Right.
But that's pretty critical.
Yeah. But blood work is often...
Blood work comes up, if you literally look at it, it could be an internal med case. We're going to do it pre-op for surgery. And I'm going to tell you, I do mostly lameness and performance horse stuff. I'm still running blood work 2 or 3 times a day. Mm-hmm. Because again, I'm looking at the health status of these athletes.
Yeah.
What are these athletes doing?
Yeah.
How are they recovering? I got a whole nother thing I've been working on called active recovery. Not ready to turn that loose yet. That's a whole different podcast, but it involves some blood work too.
Yeah.
So, but yeah, it's a new thing that I want to.
Let's get into then, I guess.
I mean, my thought is if we're going to sit here and talk about the chemistry, and we kind of touched on this for the acute phase proteins.
Yeah.
What is acute phase proteins? What is that?
So acute phase proteins are these little proteins that are made by the liver, and they are made during inflammation.
Yes. There's one. Let's talk about fibrinogen, because the 2 big ones we use are fibrinogen and SAA.
Yeah, serum amyloid A.
And fibrinogen is a non-specific marker of inflammation.
Yes, and it shows up a little later in the inflammatory cascade. So fibrinogen is, like Dan said, non-specific, but it kind of shows up. It's a later player in the game. So your fibrinogen takes a little longer to elevate than your SAA.
And the tough part there is it's a marker of inflammation, not specific for infection.
Correct. Yes.
So it can be inflammatory or infectious.
Correct.
So it has some validity. Oh Lord, I'm gonna sound old. What the hell? Back in my day, let's just throw that out there. It's all we had, right? So
when I was in school, we ran fibrinogens all the time. Yeah.
And we really thought we were doing something.
Oh yeah.
Like, oh yeah, the fibrinogen's up. And then, but when you really think about it now that we have SAA, it's like, it's an inflammatory event.
I haven't run a fibrinogen since I've been out.
I haven't run one in years. They got one panel that comes back. I don't even look at it.
Yeah.
Because like I said, it's non-specific. So you don't know if it was an infectious issue or we're just something was pissed off, angry, and inflamed.
Yeah. Because
a nerd somewhere discovered this other protein, SAA or serum amyloid A.
Yeah, it's more of an acute phase protein. So it shows up earlier in the inflammatory cascade, and it is more specific than the fibrinogen is. And we also have like a convenient little stall side test that takes like 10 minutes.
That's pretty cool.
Yeah.
I can tell you, and that was like when it first came out, we didn't have that little cool reader. You had to look at how red the strip was on the test, and you had this little sliding scale you had to compare it to. Yeah, you literally sat down.
Oh no!
And you, if you look on the back of the package, it's still there, and you had to go figure out what range you're in.
I always wondered what that.
Yeah. And I remember when this thing first launched, and we had one. The company's like, "You really need to get on board with this, Dan." I was like, "I'm good." Like, no, we really need you on board.
You're like, I can't see it.
And I finally looked at them and I said, I'm colorblind. This is not going to do me any good if I don't have somebody to read this. I cannot do this in the field by myself because I don't know what this is.
When you were helping me with that tooth yesterday, and I was thinking while I was looking at the endoscope, all I could think was, this is all gray for Dan.
Yeah, it's fine. I can do good.
I know. Anyway.
But yeah, that thing came out, and it really has been a game changer.
Yes, it's very helpful. Because like you said, when we're looking and we have to choose an antibiotic without our culture and sensitivity, we can check an SAA day 1, and then we can check another SAA at day 3 to 5, and we can say, oh, okay, we came down. We're responding appropriately to our antibiotics. We've made a good choice here.
Yeah, we win and we losing. And that's one thing I'm going to give a shout out because, I think drug companies get blamed for a lot of stuff, and they get people always like, oh, they're just money hungry and blah, blah. Yeah, they got to make a profit. But I'm going to give a shout out to Zoetis here. When they purchased this test to add to their portfolio, the amount of research this company has done.
It's a ton.
I mean, it is, every time I'm at a meeting, there's another research study they've done to help us understand this serum amyloid A. Yeah. And to go from like, oh, this is an acute marker of infection, because it's very specific for infection.
Yes.
If it's high, you got an infection. That's all we knew. And Zoetis has shown, they figured out the curves, how to use it. Because again, they're like, here's how it can help you choose an antibiotic.
Yeah.
Is your therapy working? I mean, and a lot of different things that they've done.
Yeah.
So,
yeah.
The latest one was looking at SA and folds as an early predictor for infection, like what these normal levels should be.
We used to use fibrinogen, like that was our marker. But it's late. But especially in babies, if you're 3 to 5 days behind the curve, like you're not gonna win.
No, we're dealing with 12 hours on an SAA.
Yeah.
So I mean, it's quick.
Yeah.
So yeah, big shout out to Zoetis. I mean, everybody wants to get mad at these drug companies.
No, they've done a great job with that.
If it weren't for them, we wouldn't have any of this stuff.
Right.
So
yeah.
Thank you, Zoetis.
It's cool.
But yeah, SAA absolutely love.
Yeah, it's great.
Another stall side test we have.
Oh, yeah.
And I absolutely love this one.
Which one are you going for? Because I can think of 2.
I mean, I'm an insulin guy.
Yeah, that's what I figured you were going for. I was going to talk about lactate because that's my favorite.
Oh, let's talk about lactate. That's another great one. Again, that one's really, really cool because it's again a stall side.
Yeah.
Little test strip like a glucometer.
Yeah. So the lactometers, they take 30 seconds to get you an answer. But it's just like a glucose strip. It takes 1 drop of blood.
I think it's like 15 seconds actually.
It is. Yeah. I was including the time to like draw the blood and put it on the strip. And
all right, I'll give you 30 seconds.
Yeah. And if it's cold, they don't work. So you got to put them in whatever.
You had to remember in the wintertime, they got to ride in the cab with you.
Yeah. Mm-hmm. Anyway, the lactate tells you, I always explain it to people like when you work out too much and your muscles get really sore, that's from lactic acid buildup. That's because you used up all the oxygen and your cells had to switch to making glucose for energy without oxygen. Anaerobic glycolysis. Yes, the Krebs cycle.
I still know it.
I know. I can see it in my head. Pyruvates and lactates. And anyway. But it makes lactic acid or lactate as a byproduct. And so we use the lactate to tell us it's an indirect measure of blood flow, essentially.
Yeah.
Because
if
you lose blood flow, then you lose oxygen delivery to your cells, which means they have to switch to anaerobic glycolysis, and then you get lactate increasing as a byproduct. So in horses, it's very helpful for the health of the gastrointestinal tract. So when we run a lactate, it's typically on a colic, and we're trying to decide, do we have a loss of blood flow to some section of the GI tract or not? Do we have a strangulating lesion or not? And so the biggest thing is it's helpful for figuring out, do you have a surgical case or not?
Right.
But it's very cool. We'll run a blood lactate, and if that's normal, so if it's 2 or less, then I'm like, cool. All right. Like we've got some time, we can keep on rolling. If it's greater than 2, it can go up with some dehydration, just because of hemoconcentration and things. But if it's like 7, 8 or more, I'm like, oh crap.
Things have gotten bad.
Yeah, things have gotten bad. So then I'll finish the rest of my colic workup, and then we'll do an ab tap, we'll do a belly tap, we'll sample that peritoneal fluid, and we'll run a lactate on that. And if that lactate is 2 times as high as your blood lactate, that's a strangulating lesion all day long. So it's really cool. That's my favorite like stall side test because I love a colic. But
well, it's great for me because that's like ship, don't ship.
Yes. Like,
can we ship this in manual medical therapy, or do you need to be going to find a surgeon somewhere?
Correct. Yes.
And it's kind of crazy because, again, back in my day, God, it sucks. We were measuring lactate on colics, and nobody knew what to actually do with it. Yeah, I mean, you go back 17, 18, 20 years ago.
Yeah.
We were measuring lactate, but nobody knew what the value should be and then what the value of it was.
Yeah.
So they were literally back in the days that they were just running this on every colic. It's like somebody knew this would be important.
Huh.
And literally they were running on every colic that hit the university.
Thanks, smart people.
And nobody knew what to do with it. And now I've got something the size of a glucometer hanging out in my truck. I mean, every truck's got one. We got one sitting in the lab here. I think we got 2
everywhere.
or 3.
They're squirreled away everywhere.
Yeah, because it's like the first thing, like our techs know when they come in, like we're fixing to hand them a syringe of blood.
Yeah.
And while we're doing the physical exam, like the first thing we do is pull blood. And while we're doing our physical exam, they know like we're running a lactate.
Yeah. But even my husband, who is not horsey at all, and he comes and helps me sometimes on weekends or else he doesn't see me, the first thing he pulls out of my truck at a colic is the lactometer. He's like, I know you want this. I'm like, uh-huh.
And he's like, I got this.
Yeah.
I mean, it's that cool.
It is. Yeah.
So, yeah. And one thing I want to say is, like, I know some people are trying to use this lactate to look at muscle recovery and look at fitness and things like that. We ain't got no data on this. And I think it has to do, like, when you're really talking about enough ischemia or loss of blood flow to push lactate up,
it's a lot.
It's a lot.
Yes.
It's not just a little bit, it's a lot.
Yes.
So that's why I don't think it's there. I don't think it's there muscle wise yet.
Yeah.
So.
Yeah, because there's so much muscle mass, it would be like catastrophic.
Yes.
To push that lactate up.
If you're there, I've already got CKs and ASTs that are completely unreadable, and they're going to be a faster marker than lactate is. So it's not really helping us from a muscle standpoint, but like I said, for intestinal health, I remember when y'all convinced me to start doing it because, again, we were doing it, but nobody knew what to do with it.
Yeah.
I kind of went off into sport horse land.
Yeah.
And then y'all came in like, oh, let me teach Dan about the new stuff in colics. I was like, what the heck? So this is real. And you're like,
it's magical.
And now I can't imagine doing a colic without it.
Yeah, it's awesome.
Stall side.
Yeah.
Stall side.
Yeah.
Speaking of stall side,
my
personal favorite is an insulin test.
I'd never done any of the wellness readies until I got here.
So the guy that invented it's a really good friend of mine, and we were one of the first clinics to kind of jump on it because I saw a lot of value in it coming from a podiatry background.
Oh yeah.
The thought of not having to wait for an insulin, because the worst thing in the world, right, is if you got a laminitic horse, you got to figure out why they have laminitis. Because if you don't stop that, nothing else matters.
Correct.
And when you're sitting around waiting for tests to come back from labs, like, is it cushingoid? Does it have laminitis, or does it have insulin resistance?
Yeah.
Equine metabolic syndrome. Does it have a cherry tree toxicity?
Yeah.
There's all these different causes, and you're sitting around for days watching them
be pitiful.
Yes.
Yeah, it's miserable.
And now all of a sudden, Vern hands us a test, and he's like, it takes about 15 minutes. 15 minutes.
Yeah, it's great.
And boom, there's my insulin. And that gives me a really good idea for dealing with insulin resistance.
Yeah.
But I want to tell you, this is the real power of this test. Like, it's great to figure out what they're doing from a laminitis standpoint. But here's the real power. Prevent laminitis.
I tell students this all the time because they come through and they're like, okay, like, so Dan's a farrier. I'm sure you guys see a lot of laminitis. And I was like, honestly, we prevent way more than we see here.
We're adamant. We're vigilant.
Because we push our twice yearly vaccines, as you should in the Southeast, but with our vaccine package, you get an exam. And on that physical exam, if I look at that horse and I'm like, ooh, insulin, we can run an insulin there that day. We can get an answer. And then I can adjust diet. I can adjust, management practices.
We can add medications on board.
Yes. Yeah. And it is so helpful.
And that's, like, the amount of reduction I've seen in laminitis, so with the advent of Percent, the stall side insulin test, like, now we've had it for, it's got to be 4 or 5 years. And because we've incorporated it so much into our practice, we sell a lot of Ertigo-Flows and we sell a lot of metformin, a lot of insulin wise.
Yeah.
The difference is we're selling it to horses that haven't foundered yet.
Correct.
And to me, that's the happiest thing in the world. I mean, I had one yesterday, hyperinsulinemia. It went home Ertigo-Flows.
Yeah.
And it's not foundered. It is still perfectly healthy.
Yeah.
And it's become just, the horses walk in. If they look like they're a metabolic issue, we go find out if they're a metabolic issue. And being able to do it at 15 minutes so that when your horse walks out of here, it has a medication it needs.
Yeah.
And so we can get this down and get life under control.
Yeah.
Prevent laminitis. Huge win.
Yeah.
And I think that's why this test, the stall side insulin test, not just for knowing what happens when I got the laminitic horse, but knowing, like yesterday, I had I don't know, 7 or 8 horses come in, and they were in for maintenance injections.
Yeah.
we checked every single one of them's insulin because they phenotypically had the build, their breed's predispositioned.
Yeah.
So we went through and checked every single one of them before we injected.
To make sure it's safe. Yeah.
And make sure it was safe.
Yeah.
And you know what I did last night when I got home and laid down in bed?
Didn't worry about it.
Slept fantastic. Fantastic.
Yeah. Yeah.
And that's where I remember when Vern first came out with this test, I told him, I was like, Vern, like, that's really cool. We can check it. We have a laminitic event. But I was like, do you have any idea what we can do from a prevention standpoint?
Because I've seen horses founder after joint injections, and it's miserable.
And we can adjust. And that's the thing with all the options we have out there. You have an elevated insulin. We can shift gears. We can grab one of the polyacrylamides.
Mm-hmm.
We can reach over and grab one of the biologics.
Yeah.
Like there's so many different places we can go.
We just need to know.
See, no.
Yeah.
This thing's a little tiny cube.
We have one on every truck.
It got here.
It got squirreled away too.
I was like, this is important enough. And it's not it's not expensive, but it's not cheap either. But I was like, every truck needs one.
Yeah.
Like we need to be able to make these decisions now. Because if we're out there and you're going to inject something or you are suspect of it, like we need to know now. And I guess that's where I love anything we can do here because I want to know now. Mm-hmm. I don't like going home wondering what it's going to come back.
Because we can send out, like, I guess that's the other thing about blood work is we can send out testing for
almost everything. And we have twice a day pickups. So some of these tests, like if I send it out that morning, I'll have it back that afternoon. Vice versa, that afternoon we have it back in the morning. But sometimes you just need to know now. Mm-hmm. We don't need to wait.
Yeah.
And so we've made some pretty big investments here at the practice to make sure we have the equipment we need.
Because I remember there was a time where something was wrong with the part of the wellness ready testing was on back order for a couple months, and we had to send out all of our insulins. And I was like, "This is terrible," because it takes 24 to 48 hours to come back.
And then the problem you run into is the places we use to run that. We can't get a Saturday delivery. Yeah. So if it's a Thursday, we're not going to do anything until Tuesday. Yeah. Because there's no point. It's got to stay, because a lot of these animals have to stay refrigerated, have to stay cold. And so we have to get them back. And then if we try to ship them, we can't ship on a Thursday. No. Because, or if we miss the cutoff on a Thursday when we get back, that means we got to ship Friday, but you can't ship Friday because they can't get a Saturday delivery. Yeah. Well, one, there's somebody there, but I can't get a Saturday delivery. Yeah. And so then you got to hang out till Monday because you can't ship it Friday waiting for Monday because it's going to thaw out in transit. Mm-hmm. So then you got to ship Monday to get there Tuesday to get you.
It's pain.
Yeah. So we're like, the heck with that. What can we put inside this office?
Correct.
Because we don't want our customers waiting. We don't want the horses waiting.
I'm not a patient person. I don't want to wait. Either. I need to know right now.
I want to know.
Yeah.
I hate guessing.
Yeah.
I hate guessing. Like, guessing is right in there with hope, right? Hope ain't a plan.
Yeah.
Guessing is not a diagnosis.
Yeah.
It's a guess.
Yeah.
And I tell everybody, if I was really good at guessing, I'd have picked 6 numbers, and I may even have got that Powerball by now. And let me tell y'all, probably wouldn't be a podcast. I'd probably be on a pirate ship somewhere in the Caribbean, you know?
Pirate ship.
I mean, if you hit the Powerball, get a pirate ship. Don't get a yacht, get a pirate ship. You can have a yacht too, but get a pirate ship.
That would not be my first purchase.
Oh, it's in my number 5. At least in my top 5. I mean, I'm going to do something stupid. And it may as well be a pirate ship. How can you not be happy on a pirate ship?
Are you going to get a parrot?
I don't know. Parrots poop on you. But I'm just saying, if you really think about this, could you possibly get on a pirate ship and not be happy?
Yes.
Are you serious?
If you're seasick.
I guess so. But still, let's say you don't get seasick.
Okay.
You can't be unhappy on a pirate ship.
If you're stuck in a dang hurricane, you might be unhappy.
Well, you watch the weather.
I'm just crashing dead streams.
I know. I'm just saying, like, we can put weather radar on this thing.
I mean, gonna have a motor. Ship, a modern pirate ship.
Yeah, I mean, we're gonna have a motor.
Okay.
I mean, I'm not gonna really, like, heave ho this thing around. Like,
okay.
Gonna have a captain, But I'm gonna walk around on my pirate ship. And,
Okay.
I mean, I'm just saying.
Pirate ship instead of podcast. Got it.
Yeah, I'll do the podcast from the pirate ship. This just derailed. Insulin to how you go from insulin to pirate ships?
I don't know. Guessing. Guessing is not a plan.
Guessing is not a plan.
Or guessing is not a diagnosis. Hope is not a plan. Yeah. Okay.
So yeah,
we're back.
So I think, and we don't like delayed treatment.
No.
Your horse is sick.
We need to know why.
That matters to us.
Yeah.
That matters.
Yeah.
We don't want to guess. We want to fix this because we want them better.
Mm-hmm.
So.
Yeah.
Yep.
What else? What else?
I think it kind of nails them down. I mean, we definitely got some deep dives into some of these we're going to do later, but as far as like what I consider the basics.
Oh, well, we didn't talk about PCV.
Well, I mean, we mentioned it. We got to have that. Yeah.
Yeah.
We'll do that. We're going to do another one. We're going to take like just CBC day.
Oh, man. Those
We're
white
just going to do
cells.
CBC day.
Are we going to go through the whole progenitor cells from the bone marrow?
Yeah, because I'm going to probably bash Osphos in there. I mean, not bash them, but we're going to discuss Osphos in there. Should have said that. But yeah, we're definitely going to dig into that.
Progenitor cells.
Just warning, when we put that one out, we're going to definitely have some flashing lights for a nerd alert because we're gonna.
It's always me, man.
I know, because you'll go there. You will go into Nerdland.
Yeah.
But yeah. So yeah, that's that kind of wraps up what I consider the baseline blood work.
Yeah.
Like our normal stuff, basic stuff. And I don't know why we're calling it basic, but
it's not really basic.
It's not, but I guess it's the most common.
Yeah.
The things we're doing a lot of.
It's our in-house routine. Not routine. I don't know. And it's our normal.
This is also where I want to give a huge shout out to nerds.
Yeah, the nerds are great.
And everybody bashes drug companies. Everybody picks on the nerd. But y'all, a nerd somewhere developed this test. Mm-hmm. And a drug company somewhere paid for it to get developed. Mm-hmm. So when you want to complain, just remember the nerd figured it out and somebody had to pay for the nerd. Mm-hmm. So Wellness Ready, thank you for making an insulin test.
Yeah.
Zoetis, because somebody else owned that. Say, yeah, I can't remember who owned it before, but you know what, Zoetis, great job.
Good job.
IDEX,
thanks for all the research.
Thanks for figuring out how to test everything under the sun.
Literally everything.
On a smaller and smaller amount of blood.
Yeah.
I think a CBC runs on 1/10 of a cc of blood now. 1/10 of a cc.
Yeah, that's crazy.
So when you look at your syringe next time, one of those little tick marks.
That's it.
That's it.
Yep.
Got it done. You can do something else for the rest of it.
Well, because I remember I was on small animal emergency and critical care when I was in school, and I had like a terrible, terrible, terrible dog to try to get blood on. And I took it into the lab and I was like, listen, this is all I have. And they're like, that's not going to be enough. And I was like, what do you mean? Mm-hmm. They're like, we need more. I was like, how? I can't. Do you want to go get it? Because I don't want to go get it.
And now give them a drop.
Yeah, literally.
I mean, they will get it done.
So, crazy.
Nerds at IDEX.
Good job.
Thank y'all.
Thanks.
So, thanks for being here today.
Yeah.
Thanks for going down we covered some ground today.
Podcast to pirate ship.
So, if any of our listeners out there also have ADD and would like to like and subscribe to our podcast, we'd really appreciate that. So you too can learn to segue the way we do from podcast to pirate ships.
Sometimes it makes no sense. We traced it back, though. So we're not completely insane.
I mean, we got to the point where we couldn't even figure out how we got there. But I feel like it was an important conversation. And you also learned today that anytime you use the word speaking of, it's a natural segue. So you can go like, speaking of motorcycles, I was trimming my rose bushes this weekend. And people would just like go with you and have no idea that was a really terrible segue.
Until they walk away and they're like, man.
Yeah, like what?
I don't know what's going on up there.
Yeah, if you ever need to segue, just say speaking of. And then once you say that, that can segue you anywhere you would like to be.
Speaking of segues.
Disney World.
Yeah.
Speaking of segues.
Anyway.
Speaking of segues, we got to close this out.
Yeah.
So if you like this podcast and enjoy listening to us, please like and subscribe. If you like this podcast and you don't want to like and subscribe,
That's
don't
fine.
like and subscribe. We don't really care.
We'll still be here.
Yeah, we'd love if you would, but if you don't want to, that's fine too. We're doing this for fun. We're doing this to share our love of horses and equine med. And yeah.
Pretty much it.
Pretty much it.
Yep.
So we just want to educate the world.
Yep.
So thank y'all for listening. Caitlin, thanks for being here. April, thanks for recording all this and making sure we stay somewhat on track. And Casey, when we get off track, thanks for editing and to make it look like we are on track. So again, thank y'all for listening. I'm Dan Carter here at Countryside Equine Hospital. This is Caitlin. Y'all have a great weekend. Take care.
Have a good time.